very warm welcome back to the YouTube channel of UNMICRC Institute of Cardiology and Research Center. I am Dr. Rishabh Kakoti. I am working as an assistant professor in the Department of Cardiac Anesthesia here. So today I am going to discuss regarding a topic which is a little bit of an outlier topic, that is transesophageal echocardiographic evaluation for great artery and vascular anomalies in pediatric patients presenting with congenital lesions. So starting with the introduction to this topic. So the basic principle that I want to discuss here is that in congenital anomalies of the great arteries and related vascular structures, transthoracic echocardiography serves as the initial and primary diagnostic tool as opposed to transesophageal echocardiography. So by using transthoracic echocardiography as well as by using other modalities such as cardiac MRI and computerized tomography, we can determine the extent of the vascular lesion in the great arteries, and we can formulate the surgical or transcatheter plan in the cath lab as per the requirement of the case. As such, transesophageal echocardiography does not play a major diagnostic role, but it is feasible although challenging. However, whenever these patients are put up for surgery, we can use transesophageal echocardiography for evaluation of the associated pathology, exclusion of suspected defects, and for intraoperative monitoring. So these are the lesions in the great vessels that deserve discussion in my lecture as of today. So firstly, we'll be discussing a little bit about PDA, patent ductus arteriosus. Next, we'll be going into aortopulmonary window, and subsequently into coarctation of the aorta, and then we will go a little bit into some of the rarer anomalies like interrupted aortic arch, anomalous origin of the left pulmonary artery from the right pulmonary artery, and the anomalous origin of a branch pulmonary artery from the aorta. So first, coming with one of the most common lesions in the great arteries, that is patent ductus arteriosus. As we can see here, the ductus is a remnant of the fetal circulation, and it essentially provides the communication between the aorta and the pulmonary artery. And as such, the direct imaging of the ductus arteriosus to assess the patency can be challenging by 2D echocardiography alone using the transesophageal approach. So the examination of a patent ductus arteriosus relies to a significant extent on the use of Doppler ultrasound techniques that interrogate flow across the pulmonary artery, descending aorta, and the upper esophageal views. Specific cross sections that are particularly helpful include the upper esophageal pulmonary artery and the upper esophageal aortic arch short axis to document the presence of shunting. In addition, the mid-esophageal ascending aortic short axis view with probe antiflexion and leftward rotation in the mid-esophageal right ventricular inflow-outflow view can also provide evidence of leftward shunting into the pulmonary artery, and the views of the descending aorta that allow for characterization of flow can also be helpful. Flow across the PDA can be detected by spectral Doppler assessment and canal flow mapping in the above mentioned views. So here the goal of TE is mostly in the intraoperative period, not as a tool to guide the intraoperative or surgical plan, but mostly to verify that the surgical plan results in appropriate management of the lesion, and also to evaluate for associated anomalies. And rather than going for specific view-based approach as we do in adult transesophageal echocardiography, like in all cases where pediatric transesophageal echocardiography is done for evaluation of congenital lesions, we have to go for a structure-based approach. So if the PDA is restrictive, then there is continuous left to right shunting throughout the cardiac cycle, and spectral Doppler sampling near the pulmonary artery, and in this case will display continuous high velocity flow which peaks in late systole directed away from the transducer. Also, if we use color flow Doppler mapping, it increases the sensitivity of the interrogation and demonstrates turbulent or alias flow from the PDA into the distal main pulmonary artery. However, the ductal flow can extend up to the level of the pulmonary valve or even beyond into the RV outflow tract in the presence of pulmonary regurgitation. In the setting of pulmonary hypertension, shunting across the ductus is continuous and of low velocity, peaking in the late systole, unlike in case of restrictive PDA where it is high velocity flow and peaking in late systole, and increasing level of PA pressures and the development of increased pulmonary vascular resistance are characterized by blunting of the left to right shunt in diastole, so it will become a bidirectional shunting. And in some cases, we can even find exclusive right to left ductal shunting is present, which peaks in early systole. So these are the characteristics of the flow of the blood flow which passes through the patent ductus arteriosus. So we have to evaluate, we will try our best to evaluate both the anatomical features as well as the flow features by using 2D echocardiography as well as by using color Doppler and spectral Doppler. So the presence and magnitude of holodiastolic flow reversal in the distal descending aorta also provides clues regarding the extent of ductal shunting, as increasing degrees of retrograde flow are present with larger shunts. Also, this is something that we see in aortic regurgitation also, and holodiastolic means that it is present throughout the period of diastole. The use of Doppler echocardiography facilitates the assessment of systolic pressure gradients between the systemic and the pulmonary circulations and estimation on the PA systolic pressure using the simplified Bernoulli equation. So this is a derivative of the simplified Bernoulli equation that we are using here to estimate the pulmonary artery systolic pressure, which is systolic blood pressure minus 4V square. That is the velocity of the pulmonary regurgitant jet. Also, the right ventricular systolic pressure can be estimated from the peak velocity of a tricuspid regurgitant jet, that is PASP or RVSP, that is right ventricular systolic pressure equal to 4V square, that is the peak velocity of the tricuspid regurgitant jet plus the right atrial pressure. Also, using the 2D echocardiography, we can find out the dimensions of the MPA, that is the main pulmonary artery, the left atrium and the left ventricle, which can correlate with the degree of ductal shunting in the absence of coexisting structural defects. Also, we have to assess the associated congenital lesions, that is ABCD or subaortic stenosis, representing the main indication for the use of intraoperative TE in patients with a PDA. Like I have already told, transesophageal echocardiography is usually more than enough in quantifying the lesion and in planning the surgical approach or transcatheter approach, but we can use TE in patients undergoing surgical correction of these lesions in order to confirm the findings of the preoperative echocardiogram, as well as to guide the surgical team regarding management of associated lesions, as well as to evaluate the routine evaluation of the left and the right ventricular function, as well as the valvular function. And also, it is unlikely, this is very rare after a surgical ligation for a PDA to be present. So if there continues to be one, it's important to determine the size and to ensure that another structure was not inadvertently ligated. So these are some of the TE views that we see. To the left, we see the upper esophageal pulmonary artery view, which we obtain by the mid-esophageal RV inflow-outflow view we can use, and we can withdraw the probe slightly to demonstrate the pulmonary artery. So upper esophageal pulmonary artery view demonstrates flow by color Doppler corresponding to left to right shunting across the PDA. So here it's clearly seen that there is a communication between the aorta and the main pulmonary artery, and there is flow across the PDA using the appropriate settings for image depth as well as sector size and Nyquist limit. Also, coming to the right sided panel, which shows a modified right ventricular mid-esophageal inflow-outflow view depicting the patent ductus arteriosus flow into the main pulmonary artery. Coming to the next image, which shows an upper esophageal aortic arch short axis view with color flow Doppler mapping demonstrating Elias flow from the aorta into the pulmonary artery across a restrictive PDA. So this view we can obtain from the mid-esophageal aortic valve short axis view, and then we have to withdraw the probe slightly in order to get this view. Now coming to the holodiastolic flow reversal in the descending aorta, which we can clearly see in this image, and here it is a descending aorta short axis view demonstrating the systolic forward flow as well as the holodiastolic flow reversal using spectral Doppler. Another spectral Doppler tracing which is obtained from the previous view, we just rotate the view to 90 degrees so as to obtain the aorta in the long axis view. That is, this is a descending aortic long axis view, and it shows the same type of holodiastolic flow reversal, and that is what is seen here. So next, coming to the second defect, that is an aortopulmonary window. So as we all know, aortopulmonary window is of three types, that is a proximal defect, a distal defect, and a total defect, which is related to the location of the window with relation to the great arteries. So it can be either in the proximal aspect of both the great arteries, or it can be in the distal part of the great arteries, or it can be a total type of defect where the window is a large one. So again, the same principles apply. The diagnosis is conveniently established, sufficiently established by transthoracic echocardiography alone. However, TE can be used in the perioperative management of these patients, and the aortopulmonary window is displayed by 2D imaging as a deficiency or absence, that is echocardiographic dropout of the wall which is normally interposed between the great arteries. This communication is usually large and frequently located along the anterior and the lateral aspect of the aorta in the region where the great arteries are normally in apposition. And the suggested TE cross sections to characterize an AP window are the upper esophageal pulmonary artery, upper esophageal aortic arch short axis view, mid esophageal right ventricle inflow outflow, and mid esophageal ascending aortic short axis views. Also, it can be characterized from views such as the mid esophageal aortic valve long axis view, or the mid esophageal long axis view, or the mid esophageal aortic ascending aortic long axis view, and the respective modified views. So modified views play a very important role in the diagnosis and management of these lesions. Here we are not only looking at the views as classically mentioned, but we also have to perform sweeps of the TE transducer from left to right. We may need to antiflex and retroflex, or we may need to even withdraw or advance the probe so as to obtain continuous views of the structure under interest. So that is one of the main important characteristic features of the TE examination of these lesions, so as to obtain a proper idea as regarding the anatomy and the physiology of the lesion. So coming to the comprehensive evaluation of the defect, which may benefit from the use of additional or non-standard TE imaging planes, and we can modify the views as per the anatomy of the lesion, and we can display the communication between the great arteries. So in case of an aortopulmonary window with interrupted aortic arch, there will be a large PDA with bidirectional shunting, and care must be taken to distinguish the PDA and the bidirectional shunting from the AP window. Also, we can use deep transgastric 5-chamber right ventricular outflow tract views as well as the modified views of the above, which can display the great arteries as they cross each other and can provide complementary information to the aforesaid views. However, we should remember that in the DTG views, the AP window would be located in the far field of the image display, so it will be challenging to adequately identify the communication by 2D imaging. Hence, the DTG views are better suited for the assessment of associated defects. However, we have to always keep in mind that an AP window is a relatively rare congenital lesion, and whenever we see a presumptive AP window for the first time on a TE study, especially if it has not been documented in the previous preoperative study, we must consider potential diagnostic pitfalls which can mimic this defect, such as false echocardiographic dropout that might be seen in this region. Therefore, color Doppler also verifies and characterizes the flow across the communication, providing qualitative information regarding the shunt direction and the magnitude. Also, we can use, as in all the other lesions, we can use spectral Doppler. Continuous wave or pulse wave Doppler can be used to demonstrate integrate continuous flow into the PA near the area of the defect. Pulmonary hypertension at or near systemic levels can be expected for most large defects, given the continuity at such a proximal level in the great arteries when present. So we can see here low velocity laminar bidirectional shunting across the communication as a reflection of the negligible systolic pressure gradient between the systemic and the pulmonary arterial beds. Adjustment of the Nyquist limit for the color Doppler scale will enhance the detection of low velocity flows and can be used to facilitate the detection of shunting across the communication. It is important to distinguish the low velocity color flow signal from the bleeding of color flow sometimes seen across the walls of aorta in a normal heart. Interrogation of the ascending aorta near the communication or the descending thoracic aorta may display diastolic flow reversal in the presence of relatively low pulmonary vascular resistance, and smaller restrictive defects that can display turbulent color flow Doppler pattern that responds to high velocity continuous left to right shunting across this area. So as long as the pulmonary vascular resistance is low, there will be continuous left to right shunting, but gradually the pulmonary vascular resistance will increase as a result of pulmonary overcirculation, and that can result in pulmonary hypertension and reversal of the shunt. So the peak velocity of the continuous wave spectral Doppler signal can be used to estimate PASP, and also if the TR jet is present, we can use it to estimate the RVSP using the simplified Bernoulli equation and its derivatives. Depending on the presence of associated cardiac defects, additional aspects of the anatomy should be examined using corresponding TE views as necessary. We have to, again, as I have told before, we have to make proper sweeps of the transducer, and we have to make proper maneuvers. We have to perform proper maneuvers so as to visualize the entire lesion. The hemodynamic effects of the volume load result in dilatation of the PAs and left-sided cardiac structures, and is essential in the pre-surgical evaluation to assess both the global and segmental LV systolic function best performed in the transgastric bitrapillary short axis and the transgastric basal short axis views. So we have to use that 17 segment model as proposed by the American Society of Echocardiography, and we have to evaluate both the global and the segmental LV systolic function. And at the level of the mid-esophagus, the mid-esophageal 4-chamber, mid-esophageal 2-chamber, and mid-esophageal long axis views complement the functional evaluation. Also, in the post-repair TE assessment, we will explore the potential residual shunting and patency in the great arteries to exclude obstruction of either the aorta or the PA. Also, we have to evaluate the semilunar valve competence, as regurgitation can result from the repair. Coming to some of the TE images, so this is showing an aortopulmonary window in the mediasophageal ascending aorta short axis view, which, as I have told, we can obtain from a mediasophageal aortic valve short axis view, and we have to then withdraw the probe slightly. And here it is showing a clear communication between the aorta and the pulmonary artery. But again, as I have told in the previous slides, we have to exclude the presence of a echocardiographic dropout, especially if it is not documented in the preoperative study. So this can be further quantified and this can be further verified using color Doppler. Color flow Doppler mode can be used here. And as we can see here, there is an echocardiographic dropout in the region between the arterial roots corresponding to faulty aortopulmonary septation, and shunting is verified by using color Doppler in the aforesaid image. Another image which is showing in the long axis, this is the mediasophageal ascending aorta long axis view, and this displays an aortopulmonary window in the long axis with shunting across the lesion. Also, we can use the spectral Doppler in order to determine the continuous forward flow in the pulmonary artery that begins in systole and extends into diastole, typical of aortopulmonary window. Also, coming to mediasophageal ascending aortic long axis view, which is a post-operative image which shows the patch repair that has been done, that is shown by the bright region along the wall of the ascending aorta, and this has been utilized to close the aortopulmonary defect, and we have used color flow Doppler here to rule out any residual flows. Now coming to the next part, that is, it is an anomalous origin of the left pulmonary artery from the right pulmonary artery. So here this lesion, as we can see, there is the presence of the trachea and the esophagus, and is also known as a pulmonary artery sling. So here what happens is that the trachea is positioned in such a way that it encroaches upon the LPA and it causes compression of the left pulmonary artery, and therefore also known as a pulmonary artery sling. So this lesion affects both the left pulmonary artery as well as trachea, and tracheomalacia or tracheal stenosis is a frequently observed coexisting malformation in these cases. So as I have also already told, this is also referred to as pulmonary artery sling, and the LPA originates abnormally from the proximal RPA, and hypoplasia of the LPA often is seen, and some degree of coexisting dilatation of the RPA is also noted. As I have already told, a significant number of these patients have complete tracheal rings and or other tracheobronchial abnormalities. Tracheomalia is present in nearly all patients. So this is a very big red flag whenever we want to perform TE examination in such patients. So because of concerns related to frequently associated airway pathology and potential for respiratory decompensation due to esophageal instrumentation, we should always undertake a serious risk assessment. So this is very important. We should always undertake a risk assessment prior to use of transesophageal echocardiography in affected patients. Also, instead of transesophageal imaging, we can use epicardial echocardiography, which represents a potentially safer alternative in these cases. Another reason for hesitation regarding the TE imaging in this anomaly relates to possible changes in the pulmonary blood flow caused by vascular compression of the anomalous vessel, which can be impinged further between the trachea and the esophagus as the imaging probe is manipulated. So all these factors have discouraged the routine use of TE in this anomaly and likely account for the limited reported experience. So what I am trying to make clear in this slide is that we have to perform a very thorough risk assessment in these patients, as multiple anomalies can be there, especially there can be tracheomalacia, there can be vascular compression of the anomalous vessel, and we have to keep these factors in mind whenever we plan for transesophageal echocardiography in patients with this rare lesion. If possible, avoid. That's what is being told. So the upper esophageal pulmonary artery and the mid-esophageal ascending aortic short axis views and the sweeps of the respective views are used to display the vascular anomaly, and the 2D examination also allows for measurements to measure the proximal pulmonary arteries to assess for the degree of dilatation or stenosis or possible hypoplasia. These findings should not be confused with those of an early takeoff of the right upper lobe pulmonary artery or other vascular anomalies in which the left pulmonary artery originates from systemic circulation. And therefore, the demonstration of the origin and course of the left pulmonary artery is essential to make this distinction, although it is challenging to make such observations using transesophageal echocardiography. Although color Doppler echocardiography enhances the assessment, the origin of an anomalous vessel or entire course between the trachea may not be readily delineated even using the combination of standard and modified scanning plans. Therefore, spectral Doppler can be used to provide information regarding the severity of the PA obstruction. If TE is used, the postoperative study should assess the repair by examining the anastomotic connection, the LPA, the MPA, and the nature of the blood flow across the corresponding site. So these are some of the TE views that we are using to examine this lesion. So on the image to the left, we are seeing the upper esophageal pulmonary artery view of a pulmonary artery sling, and the image demonstrates the abnormal takeoff of the left pulmonary artery from the right pulmonary artery, and also there is absence of a normal MPA bifurcation. And at the same time, we are using the same lesion, we are evaluating it through color Doppler using a variance color map, and we are evaluating the flow across the lesion. Now coming to the next anomalous vascular anomaly, that is anomalous origin of the branch pulmonary artery from the aorta. Now in this vascular anomaly, we are seeing that the main pulmonary artery arises from the right ventricle, but only one branch emerges distally instead of an expected main pulmonary artery bifurcation. The contralateral branch originates directly from the ascending aorta, resulting in discontinuity between the pulmonary arteries, also known as a lack of pulmonary confluence. Though this malformation has been referred to as hemitruncus, anatomically it should be distinguished from truncus arteriosus. This is very important because in contrast to a single semilunar valve, in truncus arteriosus there is only a single semilunar valve, but here we will be seeing two distinct semilunar valves. In some cases, the PA originates from unusual locations, particularly in the context of complex cardiovascular malformations. When the right pulmonary artery arises from the ascending aorta, in most instances there is a left aortic arch. In contrast, in the case of an anomalous left pulmonary artery, frequently the arch is right-sided. And if the anomalous pulmonary artery arises near the innominator subclavian artery, a high incidence of stenosis at the origin of vessel has been observed. So in this anomaly, primary surgical repair involves reimplantation of the anomalous pulmonary artery in the pulmonary trunk. However, if there is evidence of restriction to blood flow and or associated hypoplasia or isolation of the vessel, various strategies have been used in order to attempt to resuscitate the anomalous vessel. This condition can be assessed in combination of planes allowed by the upper esophageal pulmonary artery, mid-esophageal ascending aortic short axis, mid-esophageal aortic valve long axis, mid-esophageal ascending aortic long axis, and mid-esophageal right ventricular inflow-outflow views. In the normal heart, the pulmonary artery bifurcation typically seen in the upper esophageal pulmonary artery, mid-esophageal ascending aortic short axis, and deep transgastric views. In the setting of anomalous origin from pulmonary artery from the ascending aorta, the bifurcation is absent and only a single branch arises from the pulmonary trunk. When the anomalous branch originates near the aortic valve or from a relatively proximal site in the aortic root, its course can be demonstrated in the mid-esophageal aortic valve long axis views or ascending aortic long axis view, ascending aortic short axis view, or respective modified views. In some cases, the probe can be withdrawn from the mid-esophageal long axis view to the mid-esophageal ascending aortic long axis view, and a distal origin of an anomalous vessel can be seen in these cases. So we have to see continuous antegrade flow when an anomalous pulmonary artery branch arises from the aorta, in contrast to the systolic flow pattern expected when the vessel originates normally from the MPA. So this is also a very important parameter that we can use to distinguish the origin of the anomalous PA from the main pulmonary artery or the aorta. So in case of aorta, we will be seeing continuous antegrade flow, and in case of the vessel originating from the main pulmonary artery, which is the normal variation, we will be seeing their systolic flow pattern. So in the anomalous pulmonary artery branch originates from the innominator subclavian arteries or elsewhere, TE is not adequate to define or characterize the pathology in detail. This is because TE is very poor at imaging the aortic arch because of the interposition of the mainstem bronchus. The echocardiographic features of the anomalous origin of a PA from the ascending aorta should be distinguished from those of the other lesions, especially truncus arteriosus, where there will be a single semilunar valve as opposed to two. This is also a very important point. We have to differentiate this lesion from truncus arteriosus. As I have already mentioned, in truncus arteriosus there will be a single semilunar valve which may have multiple cusps, up to 6 cusps may be present, whereas in this lesion there will be 2 distinct semilunar valves, both of which will be tricuspid in nature. Pulmonary hypertension is a frequent finding, and TE can be used to estimate pulmonary artery pressures by assessing the flow, velocities of the tricuspid or pulmonary regurgitant jets, the gradient across the junction of the aorta and the anomalous vessel, configuration of the interventricular septum, and the thickness of the RV wall. After the anomalous branch PA has been reimplanted, the TE evaluation now focuses on the 2D imaging and Doppler analysis of the MPA and patency flow in the region of newly created confluence, and as well as in both the PA branches, particularly the reconstructed anomalous vessel. These are some of the relevant TE images. So in the left we can see that there is an abnormal aortic origin of the right pulmonary artery. We can clearly see in this view that is a modified mid-esophageal ascending aortic long axis view, which is showing the anomalous origin in the RPA from the aorta. And also there is this same mid-esophageal ascending aortic long axis view with color flow Doppler will be showing presence of abnormal flow between the two vessels. Now coming to the next lesion, that is coarctation of the aorta. So coarctation of the aorta can be of different variants. In this vascular anomaly, there is narrowing of the aortic lumen, most commonly in the region of insertion of the PDA or the ligamentum arteriosum. An elongated, narrowed aortic outflow tract is often associated with hypoplasia of transverse arch and aortic isthmus, in which case other structural cardiac malformations can be present. Historically, coarctation was classified into two types, the infantile and the adult types, but these were later classified as preductal and postductal forms respectively. The discrete obstructive shelf represents the most common form of this lesion, affecting the region where the isthmus, PDA and descending aorta join together, and is commonly currently referred to as the juxtaductal coarctation of aorta. And the contemporary surgical classification scheme has three different groups, that is isolated coarctation, coarctation with VSD and coarctation with complex intracardiac anomaly. And to each of these groups is added either isthmus hypoplasia, arch hypoplasia or both isthmus hypoplasia plus arch hypoplasia. It is extremely rare that TE would be utilized for the evaluation of isolated coarctation of aorta because of the limitations associated with imaging of the arch and the arch vessels by TE. Transthoracic echocardiography, cardiac MRI, CT and cardiac catheterization angiography are better suited to define the site and to plan the surgical procedure. Although TE has been able to recognize complications, it has significant limitations, as I have already told. If a repair via thoracotomy is planned, then TE rarely is necessary, and if even indicated, then it is primarily to evaluate the ventricular function during the aortic cross-clamp application. In uncomplicated coarctation, the primary goal of TE is intraoperative monitoring and evaluation of the anatomy and hemodynamics of left side structures once the distal arch obstruction has been relieved and the PDA has been ligated. If surgery is also undertaken to repair coexistent anomalies, here we can use TE to perform the pre-bypass and the post-bypass assessments. So anatomic and hemodynamic information can be obtained by a combination of multiple planes that display the aorta in long and short axis views. This examination is accomplished by rotating the imaging probe posteriorly behind the heart and advancing the transducer from the upper esophagus to the mid-esophagus levels. Alternatively, to the transgastric level, the probe can be withdrawn. If imaging at the level of the aortic arch, the probe can be advanced. Pertinent cross-sections include the upper esophageal aortic arch short axis view, upper esophageal aortic arch long axis view, and descending aortic short axis and long axis views. Sweeps of the TE imaging plane are also helpful to delineate the anatomy. Color flow mapping of the descending aorta can display aliasing in the affected region of the thoracic aorta or identify turbulent high velocity jets around the area of obstruction. Changes in these flow patterns can be confirmed after the repair is completed, and continuous flow from collateral vessels can also be identified in this region. Although optimal alignment of the Doppler beam may not be feasible, precluding an accurate estimation of a peak instantaneous pressure gradient across the region, flow acceleration can still be detected in this area. Blunting of the arterial systolic upstroke and a delay in the mean acceleration time can be detected by sampling the descending aorta using the descending aortic long axis view at the level of the abdomen. TE can also be beneficial in the morphologic and hemodynamic assessment of associated lesions such as a bicuspid aortic valve, VSD, LV outflow, inflow-related pathology. Use of TE in this setting allows for intraoperative monitoring, evaluation of the LV size and function, estimation of PA pressure, and identification of additional anatomic and hemodynamic abnormalities depending on the pathology. In post-operative patients with a coarctation which a TE is performed for evaluation of associated defects, the aortic arch and descending aorta can be investigated both by 2D imaging and color flow Doppler using TE views similar to those used in the preoperative evaluation. While these views are not always optimal, they can sometimes provide useful information about the status of the aortic arch or coarctation repair. Coming to some of the TE views. So this is a descending aortic valve long axis view depicting narrowing at the level of the thoracic descending aorta, which has been shown by the arrow. Coming to coarctation of aorta in a ductal dependent patient, where upper esophageal aortic arch short axis view with leftward transducer rotation demonstrates the descending aorta displayed longitudinally as well as the LPA. And when we are using color flow Doppler here, we are seeing here turbulent flow across the region of obstruction. Now coming to the last lesion under this lecture series, that is interrupted aortic arch. So interrupted aortic arch again is anatomically classified into different variants. So here there is discontinuity between the proximal and the distal segments of the aortic arch, and regardless of the type of interruption, IAA defects are always ductal dependent lesions. A significant number of patients, that is over 80%, will have a concomitant VSD. This defect is typically large and unrestrictive. The characterization of the VSD in this lesion is that of a malalignment type of defect. The corneal or outlet muscular septum is posteriorly deviated relative to the remaining ventricular septum, leading to crowding of the LV outflow tract and the resultant variable degrees of subaortic obstruction. It may be present within the context of a bicuspid aortic valve as well as hypoplasia of the aortic root and annulus. An aberrant subclavian artery arising from the DTA distal to the PDA represents a frequent finding in IAA. The definitive surgical management of the lesion consists of arch reconstruction, at which time associated defects also addressed. This may require periods of circulatory arrest or specialized cerebral perfusion techniques. In almost all neonates with IAA, TTE provides accurate diagnosis and definition of the anatomic abnormalities and is sufficient for surgical planning. Transesophageal echocardiography is rarely used strictly for diagnosis evaluation of aortic arch abnormalities. So, as I have already told repeatedly, we are very much restricted with respect to the TE evaluation of the aortic arch, because TE is not at all optimal for imaging the arch and the associated vessels. So, there is relatively limited role of TE in examination of aortic arch lesions. However, it is extremely helpful in the evaluation of the pathologies frequently associated with interrupt aortic arch, because interrupt aortic arch seldom presents as an isolated lesion. Often it is a combination of other associated lesions and can present as a spectrum of commonly related congenital cardiac lesions. The interventricular communication should be defined in terms of size, location, flow direction and velocity. In addition, the presence of additional VSD should be considered, and we should particularly examine the ventricular septum by means of the mediasophageal 4-chamber, 5-chamber mediasophageal aortic valve short axis, or the mediasophageal right ventricular inflow outflow long axis, or transgastric basal short axis and transgastric metapillary short axis views. And multiple sweeps of the ventricular septum are recommended to evaluate the anatomy fully. Also, the orientation of the outlet septum with respect to trabecular intraventricular septum should be explored. The TE views of LF assessment of posterior septum malalignment and subaortic obstruction include the mediasophageal 5-chamber, long axis, aortic valve long axis, transgastric long axis, deep transgastric 5-chamber and deep transgastric RVOT views. And the LVO outflow tract should be fully characterized in terms of size, nature of flow and patency, best accomplished by a combination of mediasophageal and deep transgastric imaging. Also, we can use spectral Doppler interrogation that can be applied to define the level and severity of obstruction if present. But all of this is contingent to obtaining a proper view, which in most cases is very difficult or sometimes impossible. Flow velocities may underestimate the severity of obstruction due to reduced integrated flow across the structures related to interruption, the presence of left to right shunting across the VSD, or associated ventricular dysfunction. Detailed measurements of the subaortic region, aortic valve annulus and root should be obtained in multiple views, and this information can help to predict the potential for LV outflow obstruction after the initial surgical intervention. And the aortic valve should be evaluated to determine the morphology, number of cusps, mobility and competence. The mediasophageal aortic valve short axis and long axis, whereas the mediasophageal right ventricular inflow outflow view are particularly suited for this evaluation. And the mediasophageal ascending aortic short axis and mediasophageal ascending aortic long axis views facilitate the assessment of the ascending aorta. Pre-bypass transesophageal echocardiography should also examine the atrial septum for the presence of communication, assessment of atrioventricular valve morphology and flows, and baseline determination of ventricular systolic function. Post-operative examination should include 2D and Doppler interrogation for residual VSD patch leaks or other residual shunts at either the atrial or the ventricular level. Also, it is imperative to assess the severity of LVOT obstruction by both qualitative and quantitative methods. So here TE can be very much useful. The same TE views used for pre-operative 2D evaluation and for optimal Doppler assessment can be used post-operative to facilitate this interrogation. So per se, TE examination for the aortic arch examination is difficult, if not impossible, but in these lesions, frequently there are abnormalities associated with the intraventricular septum as well as the LV outflow tract as well as with the valves. So we can use TE for evaluation of these lesions associated with interrupted aortic arch. As we quotation, in some cases the portions of the aortic arch and descending aorta can be visualized. Epicardial imaging can be very useful to complement this assessment. In the post-bypass examination, we have to examine the ventricular function as well as the atrioventricular valve competence and compare to the preoperative findings. And the post-operative TE should also evaluate flow across the tricuspid valve to ensure the absence of obstruction and or regurgitation or any other changes from the baseline examination. So these are some of the relevant TE views. Here we can see an interrupted aortic arch associated with a large posteriorly maligned mal-aligned VSD, and also there is hypoplastic subaortic region and aortic annulus. As seen in the left, it is well demonstrated by the arrows and the asterisk. It demonstrates the hypoplastic subaortic region and the aortic annulus, and that can also be verified by using color flow Doppler. Also, in this view on the left hand side, we can see a midisophageal long axis view demonstrating the VSD and there is a marked discrepancy in the sizes of the artery roots along with a hypoplastic aorta. Also, there is in the right side of the slide, there is a deep transgastric 5-chamber image from an infant with IAA depicting the VSD in the subaortic region, and the aortic annulus is also being measured in this slide around 4.3 43 millimeters in diameter. So this concludes my presentation for today. Thank you all for your patient listening.